Welcome everyone to Way to Basis, one of the free sessions for MRCP Basis exam. And today we are going to discuss about Station 4, communication skills. Yeah, this is the scenario. You are seeing a 65-year-old gentleman, Mr. George Campbell, in general medicine outpatient clinic. He started to develop tremor in his right hand 6 months ago. He also noticed he was slowing up and he was finding it more difficult to use his right hand. He was referred to the consultant by his GP and that was diagnosed to have Parkinson's disease 6 weeks ago. And he was started on dopamine agonist. He has returned to the clinic today to discuss further about his diagnosis and further management. So this is the scenario. Usually what we do is we just start the role play and then time it and then go through the role play and discussion and feedback, and that's what we usually do. But I get lots of feedback through like a personal message to me. But people are at different stages of preparation. So people who have just finished MRCP written part two are there, and then people who have just started preparing for PACES in the middle of the PACES exam preparation, and then who are also nearing PACES exam in just a week or two. So when we do only role play, focusing on those, people who were in the beginning or in the middle of the journey couldn't appreciate much. And then most of the people were asking me to touch on the basics of communication skills and also mainly the structure and how do we approach. This is from like a people's view. So I'm going to do like a case scenario, go through one by one, and then see how things go. Dr. Bilal, are you around?
Yes, sir.
Right. So in terms of basics, see, when I say the basics, there are certain rules in terms of how to approach station 4, and then only you can build up on the rules and then get the structure into it. So without knowing the basics, it's very difficult to get the structure and very difficult to do the role play because you might be able to do the same mistakes again and again when the basic things are not corrected. So I'm going to focus this on first, go step by step. So first of all, how would you introduce yourself in this scenario, Bilal?
Oh, okay. Uh, may I know the reason for your visit today?
Uh, no, that's where it is. That's where I'm coming from. Because see, the scenario is in front of you. Rather than asking the patient why you have come here today, the best way to start the conversation is to tell the patient why he or she has come here. In this situation, why George Campbell has come here today. And we have to tell them rather than if we ask them, they can go anywhere and then it will get completely drawn into situations. See, this is straightforward. This is about, there are 10 different teams in communication skills. We all know that. This is straightforward. You can escape by asking in terms of why are you here. But if you ask the same question in like an angry patient or like a medical errors or anything like confidentiality or a breaking bad news, we will get into the trap easily. So I would say preferably the other route of introduction. So introduction should be, yes, I am Dr. Ramesh. I am one of the doctors in the clinic. And I can see from the letter from the GP that you are Mr. George Campbell and you are 65-year-old. Is that correct? Then that means they will say yes, and that's it, finished. Then the next step is how would you like to be called? I see here in UK, each and every person has a way to be called. It's personal choice, even you and me. Some people surname, some people first name, some people shorter first name, some people have the middle name. So that's if you want to get into the style of people asking here, The next question is don't assume to say, hello, George, and then they will say, call me Mr. Campbell. And if you say every time, Mr. George, and people will say, okay, call me George. So those are the things to get the rapport initially. The first question we need to confirm is identity, name and age. Second question immediately we have to ask is, how would you like to be called? They can say anything. They can say anything. It's like a Johnson. They'll say, call me George. Okay. They can say Kevin. Call me Kev. So we need to remember that. It's not about asking and then forgetting. We need to remember that. And then every time we address, we need to address the same thing. This is very, very important to develop the rapport. If we miss this, and I come across, if for example, Margaret Thomas, you can say, hello, Margaret, how are you? And most of the time I can say, I'm not Margaret, I'm Mrs. Thomas. That's it. You will get tensed. You don't know where to go next. And then you made a big mistake or something like you have not made a mistake, but those frictions shouldn't be there at the starting of the consultation. So the first thing is now you tell me how would you and I'll tell one more thing and then I'll ask you to tell. See, one more thing is we can read out the information from the GP. In that way, we can confirm why we are here and then just narrowing down the contract between us. So this is what we are going to discuss and this is the purpose of the meeting. Rather than asking them, do you know why are you here? And then they may say, I don't know, or they may say half. And then it's all like a rapport developing exercises. No, what would you say to you have introduced and then he said, call me George. Then what do you say about the consultation? Why you are here? How would you say that?
Uh, I would like to say my name is Dr. Bilal, and I'm one of the doctor here in this clinic. And I have your letter from your GP uh, describing your problem. Uh, what would you? How would you like to be called?
Yeah, that's okay. George. Okay.
Okay, Okay, George. Nice to meet you. Uh, Uh, but can you? Your GP has written that you have a tremor in your hand. Isn't it better if you describe your problem in your own words?
Okay, again, there is a trap here because you said in terms of nice to meet you, it's always good to say nice to meet you, nice to. But again, not in all the scenarios. If the patient is very angry, the surrogate is very angry, if you say nice to meet you, how is the weather means, they'll completely grab you. That's what they're looking for. So I'm not saying don't be casual and then be rigid, but don't be too much casual. So depending upon the scenario, you need to see what will be the mood of the surrogate. You need to check and then be normal. So don't be too friendly and then don't be too rigid. Just in the middle. In this case, okay, nice to meet you. That's fine. But let's say got the diagnosis of end stage cancer and then they were talking about the dying of 2 weeks or something like that. You can say nice to meet you and think that may not fit in clearly. So you need to be careful about what you're saying. Each and every word is important. And again, here you said about tremors, and immediately you went on to ask about how is going on, and then are you getting better and things. So, anyone else want to say? How would you say this? How would you say the reason for the consultation to the patient? So, what I would say is, I would say, I'm Dr. Ramesh. I'm one of the doctors in the clinic. And you are Mr. George Campbell, and are you 65-year-old? Answer would be yes, yes. How would you like to be called? George. Okay, that's it, finished. GP referred you to our clinic, and in the letter, he mentioned about you having a tremor in the right hand, which started 6 months ago, and you also noticed things are slowing up and finding it more difficult to use your hand. 6 weeks ago, you have been diagnosed with Parkinson disease by our team, one of our consultants, and our consultant started you on the medication as well. And now you have come back to discuss about further things. Am I right? Can you please tell me, have I missed anything? That's it. So in that one, you covered everything. So no need to ask the history again and again. Because what we tend to ask is why we are here means, and then they will say tremors, and then you will ask how long was it, and what did you do. Everything is there. Finish. Straight come to the point. Don't waste your time, all those things. Any scenario, just come to the point. If you leave that, then that's finished. Okay, now you're here. Then you can ask, like, in terms of what do you think? Before me asking anything, you have come here. So how are you doing? How is the tremor? And patient will say, okay, the tremor is not getting better, but the slowing movement has got better. I would be able to do things more which I couldn't do earlier. The patient says, then that's okay, one point is out, and then now is the tremor. So now, let's say the patient didn't ask anything. What are the things you are going to ask, or what are the things it's a must here? See, communication skills is about two-way. One, we need to give some information, and then we need to get some information. So information gathering is a 50%, information giving is 50%. To prepare ourselves, what are the informations you need from the patient in this scenario? Tell me.
Uh, Sir, I would like to ask some brief questions,
Like,
uh, like uh, uh, as already patient is having the diagnosis, and what is the main concern the patient is having at the moment,
okay.
and then I would like to find out the reason uh, he came to me, and then I will talk accordingly.
Okay, so would you ask straight away after yes everything checking you're here straight away you ask okay tell me what are your concerns?
Yes, sir. Sir,
Okay,
Madam, I would like to say, can you tell me the reason? Can you tell me the reason of your visit?
okay,
Yes.
right. So what do you think are the questions from the patient in this scenario? What do you think? What do you think the
Uh,
patient will ask you?
I'm not sure, sir.
Newly diagnosed Parkinson's. What are the things patient would see? The reason I'm asking you is only when we know what are the possible questions, we would be prepared for the answers. When we don't know what the patient will ask, it's very difficult to get the answers. And it should be unexpected, surprise, shocking questions for us. Then we won't be able to answer. Any scenarios, there are a set questions where surrogate or patient will ask us. And then there are set information we need to give them. Any scenario, depending on the theme. So in this theme, let's say the new diagnosis of anything, the new diagnosis comes under this theme. Anything, Parkinson's, rheumatoid arthritis, multiple sclerosis, anything. See, anything, the first question would be how severe the problem is. So, where am I going from here? What is Parkinson's? Why am I getting it? What is Parkinson's disease? Why did I get it? And how things are going to get worse? And depending upon their previous experience, they would have seen. Let's say my mom had Parkinson's, or my friend's mom had Parkinson's. So I've seen Parkinson's in a video, advert, or anything like that with the wheelchair and then stiff and things. Do I need to? Will you get all those things? So those questions are the primary questions they definitely ask. So anything, isn't it? See, let's say, for example, diabetes. You got a diabetes. You need to know what is diabetes and how it can be controlled and what is the modes of management. You are given a medication to control it. So how long it will go? Because in the exam setup, all the that's why they get chronic diseases. They are not going to tell you about diagnosed with cellulitis, both legs, and then discuss about it. They're not going to ask. They're not going to ask about acute exacerbation of COPD. discuss the diagnosis with the patient. The moment they say the diagnosis, that means it's a chronic disease. And whenever something is a chronic illness, it has got its own implications. The name itself, it says it's a chronic, it's not going to go away completely. Any illness, like a blood hypertension, diabetes, rheumatoid arthritis, any chronic disease. So that's the key here. Chronic illness, chronic disease means that itself is a big blow. And the next question would be for some people would have thought this must be the diagnosis because they look through the internet and things. But for some people it's completely out of shock. They don't know clue about Parkinson's, but still they can know about what's going on. So that's where the question is. See if the patient asks in terms of why I got Parkinson's, what is your answer? Bilal.
uh, this disease we do not exactly know the reason why some people get this disease, but there is degeneration of a part of brain called basal ganglia, and the degeneration of this part of the brain will lead to the sign and symptom of Parkinson disease.
In this session, I'm not taking into consideration about the surgical option here because that's a different view. So we'll cover in another session. In this session, I'm not taking surgery into consideration for Parkinson's. So if we leave that out, what are the options available for treating Parkinson's and is it curable?
No, sir, no. Parkinson disease is not curable. So we cannot totally cure the Parkinson disease, but we have multiple strategies to deal with it, both with the medicines and with other strategies like physiotherapy and uh, uh, and physiotherapy.
Yeah, it's a whole multidisciplinary team. Actually. So if you, because you said that I'm saying physiotherapist, occupational therapist, speech and language therapist, and if at all anything you need to do with the social services, whether getting the funding or anything, and the carers. So those things can be done with a big team of multidisciplinary team. So that you have to mention. See, the thing is, whenever any question is asked by patient or the surrogate, we need to give the answer to reassure them. If they say it's incurable, and we shouldn't stop saying no, it's not curable. We need to say it's not curable, but we can make the symptoms under control with the help of medications and with the help of other services or part of the team. Then you have to explain it. That's the way the sentence is complete. So don't say one word answer, okay, it's not curable, and then you'll have all the questions again and again. Right. What are the things you need to tell the patient? It's a must. When you get a diagnosis of Parkinson's disease, you have to tell the patient these things a must. What are those things?
Sir, I'm not sure, but I know that I need to guide the patient according to the question the patient asks.
No, no, that is definitely there because as I said, patients can ask any questions. But before seeing, see, for example, now you will get the clue. For example, let's say you are seeing a patient who had a seizure. What one thing you have to tell the patient?
No, sir, I don't know.
Driving. Yeah, these are the key things in terms of you have to tell. See, if it's a seizure, driving. If it's something like HIV positive, and again in terms of safe sex. So it's all like a joint related, and that's what people think in terms of okay, you discuss about Parkinson's and you answer the questions, only 50% is complete because you answered only patient's question. And that's where in the 5 minutes given time, you need to note down everything in terms of okay, I need to get all those information, then I need to give all those information, then only it's complete. It's not about information gathering, only information giving as well plays equal role. Seizure, don't forget to tell about driving. Parkinson's as well, you have to mention about driving. Because of the stiffness, depending upon the severity, they can't turn their head and they can't see the mirror and things. So they can't drive literally in terms of position, posture. If it is a
Okay, sir.
Parkinson plus with all the blood pressure variations, definitely no. If it's a postural hypotension and sometimes feeling dizzy and things, definitely no, they can't.
Got, sir, got it.
Yeah. So this is the way we need to approach any communication skill station. Anything, let's say angry patient, and you have done a medical error means you need to think in terms of what are the questions they might ask and what are the questions we have to tell them and what are the things we have to reassure. How do we start? How do we conclude? This is the basic strategy for any station 4. Without this strategy, we will struggle. So, what are the ethical and legal implications in this scenario?
No,
Okay.
sir.
Right? Again, see, this is the thing. Ethical is always a standard. Ethical, the usual steps: autonomy, beneficence, non maleficence, justice. Autonomy is people's choice or people's right to know what they want to know. So we can't hide anything from them if they say they want to know anything, whether
Yes,
it's
sir.
good news or bad news or anything. See, whenever any discussion about ethical and legal, you have to start like this. All the four topics: autonomy, non maleficence, beneficence, and then justice. Autonomy is
Yes.
the people's right. You have to tell the information. If they want to know about the information, you have to tell exactly everything as it is. And then next thing is beneficence. You have to do good for the patient. So in this case, see, just because people are getting upset, you can't say, "Oh, that's okay. It's 2 3 months you will be like that, and after that Parkinson's will be okay. We can cure it." You can't say that. So doing good is you need to do exactly what's in there, both in medical as well as emotional type of things. So you need to do the correct care.
Okay.
Non-maleficence, not doing any bad things or no harm. That's more important. So you say wrong information and then you falsely reassure the patient, that is going to affect them. So you need to do that. And justice usually comes under resources management. So in this case it may not be fully evident in terms of justice. So we are not making fair and then treating people the same whatever the background is and whatever the disease is. Say if they are disabled, you can't treat them completely different than what people who are not disabled. And if they come from different region or different country, you can't treat them. So those all comes under like a justice, treating fair, using the resources fairly, not like using the resources for people we know and then not using them for unknown. But in this case, it may not be fully evident. Let's say, for example, only one special drug is there, and then you are applying to NICE to get the drug verification and also like authorization of giving the drug. Then there comes definitely justice comes. So you need to choose appropriate people and then give it to the proper person. You can't choose. There are 10 people will be applying, and then you have to give only one people the drug. You need to be fair in terms of you need to choose who is the most needy one. So that all comes under justice. Legalities, whenever anything legal, the first thing first is mental capacity. So you need to say, assess the mental capacity of that particular patient and then say whether they have mental capacity or whether they don't have mental capacity. If they have mental capacity, then you can explain to them whatever they want. If they don't have mental capacity, the next step is we need to think in terms of whether any power of attorney there, not in this situation, but any other situation, let's say talking about end of life and breaking bad news and things, and you're going to talk about where they want to die and then what is the preferred place of care and preferred place of death and so on, then their mental capacity is important and then power of attorney is important and then any advanced care plan is very important. So in this case, it didn't say like a end stage Parkinson's, but it always better to just sow the seed about advanced care plan in any chronic illness. If you would be able to do it in those discussions, it's a big plus. But if you can't do it, they're not going to put at the marks down. But if you do it, it's a plus point. Because it's a chronic illness, it's going to get worse. We are going to concentrate only on symptom management. If we sometimes ask the people about what we call advanced care plan, because now everything is okay. If things deteriorate, they will tell us in terms of the preferences, what they want to be done. And sometimes they tell us the preference, what they don't want to be done. And I'm just letting you know there is something called an advanced care plan and it's completely optional. You can tell me anything if you have any thoughts at the moment. then that's a completion sake actually. Let's say you are discussing with the patient about stopping the dialysis or something like in the middle of the dialysis, then you have to tell all about things. So that's where the chronic illness. Anybody, we have to discuss about introducing about chronic illness. First, what is it? Why people get it? Sometimes we can say, sometimes we can't say. For example, let's say autoimmune disorders, we can explain that's autoimmune. We know the reason, but we don't know why. We know the reason, explanation, but we don't know why people get it and why some people don't get it. That's where the first is. What is it? Why people get it? Or curable or non-curable? And then if it's non-curable, are there any options in terms of symptom control issues? We can management either with medications or with the multidisciplinary team. And the next thing, in terms of if things deteriorate, what we're going to do, any options left, and have you involved the family so far? Have you any thoughts about it that we can ask? At the end, definitely we have to take, we have to give the, see, this is the second time. If they ask more questions, you can say, I'm not sure whether we have given you the information leaflet. That's a way to finish any discussion about the new diagnosis or anything. Information leaflet is a must to say, because don't think we have already explained everything why people need information leaflet, because people processes differently. And let's say I'm good at reading and then I always pick things up with reading. It doesn't matter whatever you tell, how many times you tell, I won't take it in. So that's where it's a combination of things. So some people like to talk, some people like to listen, some people like to read. So information leaflet in any new diagnosis is a must and not to be forgotten in anything actually, even anything. So like for example, PCI, you're consenting some people for a procedure. If you're not doing at that time, if people say, I need to think about it, then you can say, okay, I'll give you information leaflet. All the things will be explained there. Then it's a big, good closure of giving the information leaflets. So those are the things generally. And the peculiar things or the special things, in each and every scenario, there are 3 or 4 special things will be there maximum. One of those is like a driving and then getting the practicing safe sex. So those things will come in mind. Those are the things we need to make a note before we go to station 4 in those 5 minutes. And the last one is the ethical legal considerations and then summarizing. So you can tell exactly in terms of, okay, we discussed about all these things. We discussed about, yes, Parkinson disease. Unfortunately, it's not curable, and we're going to manage with the symptom control, making you comfortable with. And yes, there's a different ways of progression of the disease, we have to say. So in this case, it's only one route. It gets worse and worse, and people get all the complications. And if they ask, you can say about Parkinson plus and all in terms of we are not trying to scare people, but we are letting them know. That's what they will come from. They will say, oh, I have seen people in a wheelchair, would I be in a wheelchair? And I've seen people bedbound. Do you think will I be bedbound soon or anything? We can't tell the timing, but there is a possibility there. So this is the course of the disease or the course of the illness. And in MS, it's completely different, multiple sclerosis. So is it the primary or secondary or staggering, different routes are there. And we don't know how people are going to be. If it's like a rheumatoid arthritis, again, you can't say people will have deformities immediately. People can do well with rheumatoid arthritis for quite a long time. So those are the things we need to tell them and educate them. From our point of view, we need to tell them incurable, cause of the disease, symptom management, MDT, information leaflets, and then about the preferred choices if they want to tell us anything in future or the future planning. How is the family, the social situation? Because again, this is about the we are talking about somebody who's going to get worse, and then how would you cope? See, some people will say, I care for my wife, and already my wife is a disabled. And then if I get Parkinson's, how do I manage? Then you can say, okay, if those situation happens, we will get from the social services and we get the carers help and then do it. So those are the things people want to know. And the first question, when I asked Bilal about what are the patient's question, those are things they'll go through in their mind. I've got a diagnosis, it's not curable. I've looked at the internet. Each and every person will look at the internet nowadays. Nobody will come to you without knowing anything. They would either look into the internet or they would have asked about because it's the life of having a chronic illness. So this is about the chronic illness and the similar theme you can apply anywhere. any of the stations. So when you know this basic clearly, and if you do this basic all the time without missing anything, it's a straightforward station in communication skills. And the most important thing is you need to recollect the information and then summarize and then get them at the end of the consultation. Do you mind telling me what we discussed today? So don't ask like I want to check whether you have got the understanding. That's not the right way. So you can say maybe I'm for my purpose. I've discussed with you. Just I'm checking myself whether I got everything right and I got everything passed on to you what I wanted to tell. So can you please tell me what we discussed so far? And then patient will tell, oh yes, doctor, you told me about Parkinson's. You told me that's incurable. And then you told me things can get worse, but we can make comfortable. There's a big team you told about. Sorry, I can't remember all the team, but you told about the team and you have given me the leaflet and that's a bit reassuring. So, and you have given me the follow-up appointments and then you give me the Parkinson specialist nurse and you told about Parkinson Society to contact people like me. So that's very helpful. That's all. Thank you. That's it.
Yeah. Regards to the advanced care planning,
Yeah.
what do you think? Which part of our consultation best to talk about the advanced care planning? Is it early of the counseling or at the end of the counseling?
In this situation or general?
Talk about the chronic disease, like those like incurable disease, like
Not
Parkinson.
early because you need to get the rapport first. I don't think
I
you
see. I see.
sometimes it's a bit risky to they get it early.
So we usually
See,
talk about that after the management or after talk about the medication or treatment or those or
yeah. See, when you talk about advanced care plan, it's going step by step. So patient need to understand that it's a chronic illness and it can get worse. When you get that understanding only, you can talk about advanced care planning. So without knowing it's incurable and then it's not coming into terms, but without knowing exactly what is happening you can't talk about advanced care planning, and that's why it takes time. So you can do it a bit later. So you can talk about okay all the reassuring things. Yes, it's a chronic illness, we reassure you, we can make you comfortable, it's a big team there, lots of medication there, everything. And then you can say usually we ask people if they thought about anything else. Have you thought about anything to tell us in future if things get worse, unfortunately? Then you can say. And whenever you see anything bad news or anything untoward, always use either I'm so sorry to say or unfortunately. Don't say straight and say, what do you think if things get worse? Can you tell me? Don't say that. I'm sorry to say, this thing can get worse. In those situations, do you have anything to tell us? That's a way to start the conversation. Right. Any questions? No questions? Good. So this is how I will suggest you to approach any scenarios. So if you read a scenario, just think about it. What am I going to do in this one? And what are the questions from the patient? What are the do must things in terms of questions or information I'm going to give? For example, any legalities I need to touch on and get all the information and be ready in the 5 minutes. Then you can tell everything. If you go blindly with the scenario, you might get caught. You might do very well. That's okay. If that's the way you practice all the time, you will do very well. But in case if something unexpected comes, we don't want to be tense or anything in the exam. So always plan nicely and get every team. You have a structure like this. If you are discussing about confidentiality, have a structure. What are the things to discuss, what or not? And then medical error separately. End of life, yes, separately. Palliative care, yes. And then again, this is about chronic illness, okay, consent for the procedure. So there are only few teams, it's not a lot. So every team, you need to get the basics right and then see how things go. One last time, any questions? Either you can do it in a chat or talk it through. No? Okay. So I will stop the recording now.